This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. Today, I'd like to provide you with an overview of acute pulmonary embolism.
A pulmonary embolism is defined as obstruction of the pulmonary artery or its branches by materials, whether thrombus, air, fat, or tumor, that originates from outside the lungs. Presentation can range from asymptomatic, sometimes an incidental finding that's found on a CT scan done for other indications, to patient with dyspnea, to more extreme cases of sustained hypotension, RV dysfunction, shock state, and sometimes even death. Pulmonary emboli can be classified into acute, subacute, or chronic. Chronic pulmonary emboli are usually associated with chronic thromboembolic pulmonary hypertension, or CTEPH. To develop pulmonary emboli, we usually see patients having at least one or two, sometimes all three, of Virchow's triad. Virchow's triad are conditions that are required to form pathologic thrombus. Stasis or low flow, injury to the endothelium of blood vessels, or hypercoagulable states are the three elements of Virchow's triad. Most pulmonary emboli do arise from proximal lower extremity veins, typically between 80 and 90%. Half of patients with proximal lower extremity DVTs have pulmonary emboli, either clinically or picked up routinely on a CT scan. It's important to note that when we diagnose a proximal lower extremity DVT, it's not critical to look for pulmonary emboli if the patient's not symptomatic, or even if they are, we can assume they're having pulmonary emboli. And the reason is treatment of proximal DVT with or without pulmonary emboli are really the same treatment. It's considered one disease. We sometimes call it chronic or acute thromboembolic disease. We need to follow up all patients that are in the hospital or the ER with pulmonary emboli, and the follow-up is a common reason for office consultations in our practice. We'll see people that had been in an ER or had been hospitalized with orthopedic procedures that were found to have a pulmonary embolism. They all need follow-up, and they're frequently sent to a pulmonologist's office. So this is an elastic stain of a large caliber pulmonary artery from a patient with a prior pulmonary embolism which has now organized. Within, there are fibroblasts and collagen matrix. You can see that the lumen is totally occluded with organized thrombus. In this CT angiogram of the chest from one of my patients I saw in the hospital with a large central pulmonary embolism, we'll move down from the head towards the feet through axial slices. So I'm going to show you the aorta is dividing right here, and then this is the central pulmonary artery. Let me slow this down. There is a clot that's the filling defect right in the middle here. It's bridging over the middle from the right side, which is on the left of the screen, and then that's a saddle embolism. And as we move down, we see all of the branches, or a large number of the branches, have occlusions right in here. And over here, we'll see one of the branches is occluded. The other ones are patent as they're fully opacified. Let me let the video run all the way down. You can see some clots over here, little thrombus right in this vessel, all the way down. So we really see multiple pulmonary emboli in that slide. Let's turn our attention to acute pulmonary emboli. Acute PE is usually diagnosed in the ED or in hospitalized patients. We suspect pulmonary emboli in patients with new or worsened dyspnea, chest pain, or sustained hypotension without alternate diagnoses. Worldwide, 20% of patients evaluated for pulmonary emboli have PE confirmed, where in the United States, that percentage is much lower due to a very low threshold for workup, given our litigious society. We should be evaluating patients with a reasonably high suspicion, either clinical grounds or a formal score such as a Wells score, which takes into account risk factors, symptoms, and presence or absence of alternative diagnoses. The gold standard study now is a CT angiogram, but if unable to do a CT angiogram, most of the time that's because of either dye allergy or elevated creatinine. A VQ scan is a second alternative diagnostic modality. The problem with the VQ scan is in patients with suspected pulmonary embolism, not all patients have a diagnostic VQ. A high probability scan in the right circumstances fairly confirmatory of suspicion for pulmonary embolism, and a normal scan pretty much excludes PE. Its sensitivity is about 96%, or the negative predictive value, I should say, is about 96%. But many of these VQ scans come back as low probability or indeterminate, sometimes referred to as intermediate. Patients who have low probability or indeterminate / intermediate scan results on a VQ scan usually need further evaluation, whether that's with a D-dimer, which may have already been done, or with duplexes of the legs, or a contrast study if that can be arranged, with prophylaxis, or just dealing with the side effects with respect to renal function. Now, in patients with a low or medium suspicion, before doing a CTA, we do a D-dimer, and if that's negative, we don't have to go on to a CT angiogram, and we reserve CT angiograms only for patients with D-dimers if we're not positive D-dimers. If we're not able to get a CT angiogram, we can do VQ as an alternate study. So why are we so confident about not doing a VQ scan or CT scan in someone with a negative D-dimer? The sensitivity of a D-dimer at a threshold of 500 micrograms is 99.5%, although the specificity is lower. What that means is virtually all people with pulmonary emboli have a D-dimer over 500, so that a negative test under 500 has an excellent negative predictive value and can exclude the diagnosis with a high level of confidence. Because the test is nonspecific, a positive D-dimer, let's say 700, does not mean by any means that the patient had a pulmonary embolism. There are many other things that cause D-dimer. The ones that we see are post-operative from coagulation going on. Another one is sepsis syndrome, can raise the D-dimer. So the test overall is excellent in ruling out PE, but not very helpful in the positive sense in ruling in. People with positive D-dimers typically have to go on to further diagnostic testing, as I mentioned just above. That would be a CT angiogram, or if you can't get one, a VQ scan. So let's discuss consequences of acute pulmonary emboli. First of all, we have gas exchange abnormalities. Pulmonary emboli cause VQ mismatches from mechanical obstruction of small and medium-sized pulmonary artery branches, lung injury, and inflammation. There is shunting from areas of atelectasis, and the atelectasis is worsened by surfactant dysfunction. So when you develop an area of atelectasis, blood can go through it, and the blood doesn't have a chance to pick up oxygen. That's what we mean by shunting. We also have some shunting by diverting blood that can't get to one part of the lung to areas of the lung that are either unventilated. So we can force blood away from a zone that it would have gone to a poorly or unventilated zone. That can contribute to VQ mismatch or even shunting. Another consequence of PE with respect to gas exchange is an increased respiratory drive from the hypoxia and the inflammation. This leads to respiratory stimulation and is followed by hypocapnia and respiratory alkalosis. So unless someone's ready to have a cardiopulmonary arrest, most patients with an acute pulmonary embolism have a primary respiratory alkalosis. Next consequence of acute pulmonary emboli is a pulmonary infarction. This is seen in about 10% of patients with pulmonary emboli. The reason we think it's not seen more often is that the lungs are protected by three different sources of oxygen. First, there's pulmonary artery. Although it's venous blood in the pulmonary artery with saturations of 70%, there's still a fair amount of oxygen going to the lungs in the pulmonary artery. The second source is the bronchial circulation. The lung has a primary arterial circulation that's well oxygenated at systemic oxygen levels in the 90s. And the third source of oxygen to the lungs is the direct ventilation with oxygen spread throughout the lungs through the airways down to the level of the alveoli. So we have some protection for pulmonary infarction by this three sources of oxygen, but it does happen. When patients have a pulmonary infarction, they'll complain of pleurisy or have hemoptysis, and we can see intense inflammation. We will see a wedge-shaped peripheral infiltrate, which heals over time as a Hampton hump. I'll show you that in just a minute. Patients with acute pulmonary emboli can become quite unstable. At a minimum, they may show RV strain with an associated troponin leak or progress to right heart failure when there's over 75% or so of the cross-sectional area of the pulmonary vascular bed obstructed. And in the case of severe obstruction RV failure, we can have obstructive shock. So this first slide is a patient with a pulmonary infarct, and we can see a little wedge-shaped peripheral pleural-based infiltrate. Now this patient had a CT angiogram to diagnose the pulmonary emboli. This is not the right view to see it because these are lung windows, but you can see a triangular pleural-based wedge-shaped infiltrate. So we presume the artery that's feeding this segment is closed right here. So the shape of the infarct is pleural based on triangular because that's the distribution of this one branch of the pulmonary artery. Now these will heal as a Hampton hump. So that's a little faint, softer, rounder. Let me blow that up a little bit for you. So we'll see a little pleural round abnormality that somewhat looks like a camel's hump, called a Hampton's hump.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.